Diabetes Connections is brought to you by Inhaled Insulin. Fast in, fast out fits your lifestyle. And by Dexcom, keeping you in control with an integrated system for diabetes management.
This is Diabetes Connections with Stacey Sims.
This week, Eversense is the CGM that goes under the skin and stays there for, at this point, 6 months. The company that makes it has big plans to make that time period longer and to make the sensor even more accurate.
Our next generation, of course, this is our third generation. We're already on to our fourth and fifth and envisioning even more beyond that, is to have it last, hopefully up to a year. At that point, to calibrate once a week.
That's Senseonics Chief Medical Officer, Dr. Francine Kaufman. We had a wide-ranging conversation about everything from sensor length to interoperability and working with different pump systems, as well as access, and a lot more. This podcast is not intended as medical advice. If you have those kinds of questions, please contact your healthcare provider. Welcome to another week of the show. I am always so glad to have you here. You know we aim to educate and inspire about diabetes with a focus on people who use insulin. And if you are listening the day this show goes live, today is my local book launch. Still the World's Worst Diabetes Mom, my new book, is available wherever you buy books online. But here in the Charlotte, North Carolina area, I am doing an in-person event, and that is today, November 15th. It's tonight at our Birkdale Village. It's a lovely little local shopping center at Kendra Scott. I won't talk about it too much here because obviously the vast majority of you don't live in the Charlotte area. But big thanks to Kendra Scott. They are a jewelry store chain that does really good give back work. They do a lot of work with charities. So JDRF is having all of these give back events tonight across North Carolina. They're probably having some stuff where you live too, if you want to check that out. So we made the Birkdale Village event my book launch event. I'm really excited about this. The response to the book so far has been great. I was a little nervous because there's some not so popular opinions in there about raising a child with diabetes, including things like not oversharing and not just numbers, but not posting so many pictures of our kids online. Anyway, I won't go into too much detail here. The book, as I said, is available Amazon, Target, Barnes & Noble, all online. If you want a signed copy, the only way to do that, other than meeting me in person, I've got some events coming up. I'll talk about that later. But you can go to diabetes-connections.com, click on the shop tab. There is now a little bookstore there. And if you use the promo code THANKS, that is all the month of November, use the promo code THANKS, you will save $2 on any purchase in the bookstore. We also have some free downloads there if you haven't been there for a while. We've got guides on things like getting your gear to stick in the hot weather, getting your diabetes stuff organized at home and when you travel. And there is a brand new free download going up. It should be there already, specifically about travel. My top tips for travel with diabetes, as well as a packing list that you can print out. So check that out. That's all at diabetes-connections.com under the shop tab. But a lot of what is in the shop is free. All right, my guest this week is Dr. Francine Kaufman. Some of you know her work, but she is pretty amazing. She is currently the Chief Medical Officer of Senseonics. As I said, that is the company that makes Eversense, the product we're going to spend most of this interview talking about. She is also an attending physician. She still sees patients at Children's Hospital of Los Angeles. Before Senseonics, she was the Chief Medical Officer and Vice President of Global Regulatory, Clinical, and Medical Affairs at Medtronic Diabetes. She is the author of hundreds of peer-reviewed articles and many books, and was the president of the American Diabetes Association in the early 2000s. So her work and her accomplishments go on, and her enthusiasm and her interest in this community, it's so apparent. She really is absolutely amazing. Quick note about the product that we're talking about here. She will describe it if you're not 100% familiar, but Eversense E3 is what we're talking about here. It was approved in the U.S. earlier this year. It was approved in Europe more recently, and it is an up to 6-month under the skin CGM. There's a lot more to it than that, of course, and I will let Dr. Kaufman, by the way, she says, call me Fran, so I do. I will let her explain it in just a moment. But first, Diabetes Connections is brought to you by Afrezza. And every time I mention it, you email me, the DMs come in with questions. So what is it all about? Well, Afrezza is an ultra-rapid-acting mealtime insulin. You breathe it in using an oral inhaler. Afrezza gives you the flexibility to eat when you want while providing proven blood sugar control. Afrezza's ultra-rapid action allows you to inhale your insulin right when food arrives, even unexpectedly, so you can be spontaneous but still in control without the need for injections at mealtime. Find out more, see if Afrezza is right for you. Go to diabetes-connections.com and click on the Afrezza logo. Afrezza can cause serious side effects, including sudden lung problems and low potassium, and is not for patients with chronic lung disease such as asthma or COPD, or for patients allergic to insulin. Tell your doctor if you ever smoked, have ever had kidney or liver problems, a history of lung cancer, or if you are pregnant or breastfeeding. Most common side effects are low blood sugar, cough, and sore throat. Severe low blood sugar can be fatal. Do not replace long-acting insulin with Afrezza. Afrezza is not for use to treat diabetic ketoacidosis. Please see full prescribing information, including boxed warning, medication guide, and instructions for use on afrezza.com/safety. Dr. Kaufman, thank you so much for joining me. Always a pleasure to talk with you. I'm so glad to have you back on the show.
Well, I'm glad to be here. Thanks.
Before we get into all things Eversense, I'd love to take a moment, if I could, to ask you about a recent trip. You are back from the Caribbean, where I understand were you seeing patients?
So I was mainly teaching as part of Life for a Child, which is this really, really super important organization started by an amazing individual, an Australian, Dr. Graham Ogle, to around the world actually help support children who otherwise would not have access to education and supplies. Insulin's brought, finger stick monitoring, A1C capability. But the most important is to first train the individuals who be caring for these patients around the world. So in India, in South America, Africa, and now also obviously in the Caribbean, which is where I was, and had the opportunity to work with two amazing physicians trained in Cuba and who are now caring for children on the islands of Antigua and Barbuda who have diabetes and really wanted to be educated as to what the possibilities are to help them improve their health.
We followed that program, not necessarily that exact program in that city, but we followed that program for many years. I know many of my listeners have donated. We've done campaigns with them. I personally have donated. It's wonderful to get an idea of what's actually happening. Can you speak a little bit to the need or any specific examples?
So I've had the opportunity through Life for a Child to go to Ethiopia, to go to Bangladesh, the Caribbean, and of course I did a lot of work in Haiti for a number of years, which was also in conjunction with Life for a Child. So I mean, it's just this phenomenal program that does a deep dive on where they go and what the needs are. So Antigua, the government actually allows the children to get regular and NPH insulin in about 3 strips per day, which sounds like what we were doing 20 years ago, but at least is something. Obviously, in Haiti, there's no government support for what's going on, so all the supplies need to be brought in. So it all depends on where they are, what the needs are, but it is really trying to meet their prime directive, which is no child should die from diabetes.
It's such a stark reminder of, as we're about to talk about technology and the latest and greatest, right? And what many of us have access to in the States, to the idea that diabetes is still, I hate to say it this way, it's still a death sentence, or it's still something to see, to overcome in a way that many of us don't think about it in much of the world. Do you feel like that's getting better?
I think it's getting better. I mean, certainly the International Diabetes Federation, which is going to meet soon in Lisbon, lots of effort from the JDRF, the ADA, and certainly nonprofit organizations like Life for a Child to focus on the needs across the globe. And you're right, we sit here, we're trying to debate which AID system maybe we should get, which continuous glucose monitoring system we should have. And there are children, and obviously adults as well, around the world who can't even get access to insulin. So a lot of disparity. We need to work to help eradicate that.
It seems like a very small thing to do after this, starting out with such kind of a heavy topic, but I will put a link in the show notes to Life for a Child, to the things we talked about, and to also, if you're listening in the United States, there are programs here as well for people who can't afford insulin and need better access. So we will link all of that up. It's a little difficult to switch to that to talk about the latest and greatest, Fran, but I would like to. That's why we have you on to talk about Eversense today.
Right, and we should appreciate what we do have and work to use it to the optimal.
No doubt, no doubt. Things are getting better in many ways. So to make a hard pivot, Let's talk about this because the E3, the much longer sensor and transmitter system, was approved in the United States earlier this year and now has CE mark and is rolling out in Europe. Remind us what we're talking about here. How long is this sensor that goes under the skin with a transmitter that sits on top?
So this is a fully implanted sensor. It's the third generation of the Eversense system. The first one was a 90-day sensor in the United States. Then we did get to a 180-day sensor called the XL system outside the United States in some European countries. And now they're getting this third generation system that also lasts up to 6 months. So fully implanted, the transmitter sits above it. The transmitter is removable, rechargeable. So if you have an instance where you don't want to wear something on body, you can take that transmitter off. Of course, you're not going to get CGM data at that point, but you have that option and then you can put it back on and the CGM data reappears within 10 minutes. So this Eversense E3 system is enhanced in a number of ways. The chemistry of the sensor itself has been altered. The firmware inside the transmitter, the app, everything has been upgraded and innovated upon. So this is our third generation product, and we're really excited to have it in the US already, and now to have it in Europe as well.
And when you say you put the transmitter back on, and in 10 minutes, the numbers come back, the past information repopulates as well, correct?
No, there's no past information because the transmitter is the energy source for the sensor. So when that transmitter is not on top of the sensor, and of course it's held in place with a mild silicone adhesive that has a low skin reaction rate. But when that transmitter is not on, the sensor is dormant. And when it's put back on through near field energy, it excites these little LEDs inside the sensor. They light up the sensing surface and you can see, or the sensor can see, the amount of glucose in the interstitial fluid around the sensor, which is where all the other transcutaneous sensors are measuring glucose as well.
Just so I can understand, and I hate to immediately start comparing this to competitors, but truly just to try to get some information. So in other words, like when my son's phone, or in the olden days, receiver was not available for the Dexcom, once it was available and reconnected, we could see past information. And there's a software system called Clarity where you can look for, you can look back for months and months. Not the same with Eversense?
So the same. So when the transmitter's on top of the sensor and the sensor is being activated every 5 minutes to come up with a reading, if you don't have your phone, the transmitter is holding on to all the data. So as soon as you get back to your phone, you will backfill all that data as well.
Right. So, but when the I'm sorry, I'm conflating two different things. I was saying the phone for the Dexcom because you can't separate the transmitter and the sensor. It won't work if they're separated. When the transmitter is not physically on top of that sensor, whatever information is missed will not be repopulated ever.
Right. But when the transmitter is on and the phone is not near, when those two come together, you'll backfill everything that needs to be backfilled, just like you do with the transcutaneous sensors.
Got it. Quick question about...
I want to say one other thing. Yeah. When that transmitter is on and the sensor is activated and your phone isn't nearby, you will get alerts right on your arm from the transmitter itself for both high and low glucose values. The little signals are a little bit different, so you can differentiate whether you're getting an alert for a high or you're getting an alert for your low. But so you don't have to have your phone with you all the time to know that you've got a glucose aberration.
Go ahead. And just if I could ask you to elaborate on that, that's a vibration, right? Not an audible alarm.
Right. It's a vibration. It's very discreet, so nobody else knows that it's occurring. And of course, at the same time, if your phone is nearby, you'll get an auditory alert, you'll get a visual alert. But we find a lot of our users really, really appreciate what we call this on-body vibratory alert system.
Yeah.
So that they don't have to have their phone with them all the time. They don't have to be looking at their phone. They can be up there, giving a talk on the radio and just feel it on their arm and not have to have anybody else know it's going off.
You also mentioned the adhesive already, and I saw a great video of Chris Rudin, who is someone who's been on the show before, bodybuilder, athletic competitor. I don't know how to describe Chris. He's an author. He's just a great guy. And he did a video where he was taking the transmitter on and off and on and off, kind of showing how well the adhesive works. It's not a one and done. Is that still the case?
Right. So what the regular routine for somebody using Eversense E3 CGM system should be is they wake up in the morning, they take the transmitter off to recharge it. It takes just about 10 minutes. Take their shower so that they have nothing on their skin and they can completely cleanse their skin. Come back out of the shower. The transmitter's now been recharged. Put it back on with a mild adhesive that hopefully is changed every day, and then go about their day. But if that turns, at noon, you hit a door jam and it falls off, the transmitter falls off, you can just pick it up, put it right back on where that adhesive is, and you've got no loss of a sensor. It's just a replacement of the transmitter.
Can you tell us anything about that adhesive? I mean, it's just amazing to think about how it would work where you can kind of take it on and off and it still sticks.
I mean, again, you have an adhesive for every day. But during that day, if the transmitter falls off and the adhesive comes off with it, which is unlikely, then it will re-stick again. But if the adhesive stays on and just the transmitter falls off, you can re-stick it as well. I mean, it's a mild silicone-based adhesive. It doesn't have some of these acrylates. It has no acrylates in it that we know have in the past been something that skin reacts to kind of adversely. So it's very hypoallergenic. And again, because it's removed every day and you give the skin a chance to breathe, it really does have a low skin reaction rate.
Let's talk about accuracy. The MARD for the E3, I believe, is 8.5. Is that correct? Has that changed? Did it improve?
That is correct. So that is the E3 MARD, across the entire lifespan of the sensor, across all the glucose ranges of the sensor. And it is something we're very proud of. In the low range, it's actually a lower MARD. So it's in the 7.7 to 7.5 range for 40 to 80. And as a result, we have many users who appreciate that accuracy in the low range and have chosen Eversense as a result because they're either hypoglycemia unaware or very concerned about hypoglycemia and want that accuracy so that they can prevent a serious adverse event.
One of the things that I get asked a lot by listeners is about calibration because, other CGMs, well, there's not that many, is about calibration. Dexcom got approval for G6 with no calibration for insulin dosing. Medtronic has not, and Eversense has not. Is that something that you're looking to move toward?
In all honesty, which is, of course, why I'm here, we likely, with a long-term implanted sensor, will never get away from some calibration. Our next generation, of course, this is our third generation. We're already on to our fourth and fifth and envisioning even more beyond that, is to have it last, hopefully up to a year. At that point, to calibrate once a week. And we may have an interim step where maybe we'll have that fourth generation sensor available. It will be a fundamental change in some of the sensor manufacturing and components and how it's all put together that we would be able to have maybe up to 6 months with one calibration a week. But, we're very excited about that, but we likely will never get to zero calibrations with a sensor that can last up to a year. But we're going to save you time in that you don't have to replace anything, you don't have to order anything, you don't have to store anything, you don't have to carry anything else with a sensor that lasting now 6 months and, hopefully soon lasting up to a year.
All right, let's jump right in. You mentioned the future iterations of this. Obviously, longer lasting is something that we're working very hard on. Are there other features in the fourth or fifth generation that you can share?
There's certainly are. Obviously, to reduce calibration, to have longer lasting, to keep the same, if not continually improving the accuracy. Those are our goals. So one of the next generation will have a fundamental change in the makeup of the sensor so that it can be sensing in multiple areas at the same time, which we know will keep that accuracy and allow us to decrease the frequency of the calibration. Then we have the ability to add a battery at the end of the sensor. It will make the length of the sensor a little bit less than double. The diameter won't change fundamentally. But what that would enable is you could then take off the transmitter. The battery will power the sensor. So if you put the transmitter back on, you will be able to backfill.
I see.
And you'll be able to see those. But when the transmitter is off, you'll be able to get intermittent scanning or flash glucose measurements in between by just holding your phone up there and seeing what the latest glucose value is without a transmitter. We would be able to then combine, what one system, the Libre system, has had out for all this time, and a real-time continuous glucose monitoring system into one device.
I heard a couple of my listeners sit up and say, just give me the flash one right now.
Yeah.
Just the battery-powered sensor with no transmitter on top of it. I can't imagine that is something you're trying to develop, because why not keep it all together?
We may have two products, one without, a transmitter at all, and the other one with the transmitter and the option to take that transmitter on and off. So that if we have what we're going to be calling a freedom system, so there's no transmitter at all, then all you'd be able to do would be to scan it. With the backfill, with being able to get the data into a data management system so you can look at it retrospectively yourself or with your healthcare provider. That's what we're working towards. So obviously getting that battery on and functional and everything is what all the engineers are working on at this point.
God, that's just fantastic to think about, the options for CGM. I was talking about this with Benny the other day because he remembers very little. He was diagnosed so young. And he doesn't remember life before CGM. He was 9. He was a little older. We went 7 years with no CGM. But he doesn't really remember what it was like to not see the information and to not use it so integrally to his care. I'm going to talk to you later. You've been doing this for a while and you've seen a lot of changes as well.
Oh, I started practicing before we had blood glucose monitoring at all. So
yeah, I mean, it's amazing your perspective on this. Well, let me jump to it right now. I mean, we have more questions on Eversense, but Benny, like I said, he doesn't remember it. For you, I'm getting ahead of myself because I wanted to talk about this later. But it must be remarkable to go from, as you've said, you were in practice before blood sugar meters were around, or at least, given to patients to take home. And now here we are saying, well, maybe we'll have an option to scan it when it's under your skin, or maybe we'll have an option to put a transmitter on it.
Right. No, we come a long way. It's interesting. When I get a new patient, they often look at all the technology and wonder why we haven't cured diabetes. Well, obviously that effort has been ongoing throughout time when we were able to even conceive of what the pathophysiology of this disorder is and how to approach some kind of cure with returning beta cell function. But what I want to tell them is, although we haven't cured it, we've come so far from when I started my career almost 45 years ago, where all we had was animal insulin and urine testing and really no concept as to how patients were doing. We didn't have A1C either. So we got 4 glucose measurements a year when the patients would come into clinic. And there was no dose adjustment. It was a fixed dose that would be changed every quarter when the patient showed up for their clinic visit, and changed on a fasting glucose value that you got in the clinic that day. So we did see, obviously, a much higher rate of complications and issues, particularly with children with type 1. And now, fast forward to AID systems, implantable, long-term continuous glucose monitoring, insulin pumps, new insulins, insulin analogs. Imagine that we no longer see those complications in children, that children grow and thrive and come close to near normalizing their glucose values, and what that does to their long-term health, so that a child in a developed country born and diagnosed at age 10, has a full life expectancy. But I do want to bring back what we talked about at the beginning with life for a child born in a under-resourced country diagnosed at age 10 might live only 13 more years as a result of lack of access to the basics that are required to manage this disease.
It's hard to think about it. It is amazing to see how far we have come, but so far to go in so many parts of the world. Speaking of kids, can I ask you, are there plans for a pediatric version?
There absolutely are. It's a question of putting children, likely adolescents and above, into our next clinical trial with our next product. We're looking forward to doing that. We know that there are patients in the pediatric age range, mainly adolescents, older adolescents, who have physicians who have used off-label. We're not promoting that in any way at all, but there is always off-label use of any product. So we want to get the data, be sure, that we can supply to those particularly older adolescents who want the device, who, because of sports, because of lifestyle issues, because of accuracy, because of the on-body vibratory alerts with the transmitter, would really choose to have Eversense as their CGM product.
I do know an adolescent who is soon to be an adult, which I cannot believe, who would love to have taken part in those trials, especially with Benny wrestling in high school. He really, really would have loved to use something like this. But the sticking point for us wasn't so much the off-label use. It was that he's had so much success with an AID system, with an automated system that works with his insulin pump. I got to believe you all are thinking of this or working towards this. Can you share any plans?
We live, eat, and breathe that. So we're in the midst of a trial. It's almost completely enrolled, and we'll, hopefully be able to submit to the FDA sometime early next year.
Is it public knowledge who the pump partner is?
Well, so this isn't about a pump partner at this point. This is about getting this criteria called ICGM.
Oh, yes. Okay.
CGM criteria. And then, we've talked to lots of pump potential partners. So they're interested as well as obviously we are too.
I got ahead of myself because exactly, you've got to get the ICGM designation. There have been interesting sticking points with that, and they haven't been made fully public, but in terms of things that have held up other CGMs, like, how they interact or how they respond perhaps to vitamins or other medications, anything you can share or talk about with how, I know the answer as I'm asking with clinical trials, but, anything to share about how that's going?
Well, so our clinical trial is going very well. We do not have interference with vitamin C or Tylenol. We do have interference with tetracycline.
Oh.
That is one issue for us. So if somebody needs a course of tetracycline while they're using Eversense CGM, they need to, look at finger sticks to make their management decisions. And, if somebody's on a chronic lifetime course of tetracycline, we are not the product for them. But on the other hand, Tylenol and vitamin C have no interference with our system.
Remind me, tetracycline is an antibiotic?
It is an antibiotic, yes.
Interesting. Can you speak to why that happens? Not just with tetracycline, but it's so fascinating. Like you mentioned, Tylenol, which hung up Dexcom for a while, vitamin C, which is the problem with Libre. It's just the way the body and the equipment responds to these kinds of things and gives false readings. Is that the issue?
Right. It's not the body. It's the sensors.
Sure, it's the sensors
themselves interacting. So our basis is a fluorescence, and the tetracycline class of antibiotics actually has the ability to change kind of fluorescent patterns. So that's how it interferes with us. And the other ones interfere with the enzymatic way that the glucose is monitored and measured in the other systems. So it's a real just pure chemistry kind of issue.
That's so fascinating. We could do shows and shows on that alone.
Yeah. I don't know if anybody would want to hear a whole show on that.
Oh, you'd be surprised.
Obviously, that the FDA, in their ability to put the patient first and think of safety, asks that all these products are measured against, and a lot of this is just done on the bench, all the compounds that one would likely take or could likely take to see if there's interference with glucose monitoring as a result.
I'm trying to think, when it comes to interoperability, like you said, you need the ICGM designation first, but with interoperability, with working with pumps, I'm trying to think, would there be anything that I can ask you or anything you'd like to share about that once you get the designation? I can't imagine there's much to share yet.
Well, there isn't. Obviously, there are the known AID systems that have been approved. There are AID systems and pumps that are in the process of getting approval or getting close to getting through the process of approval. So we've talked to what you know about, as well as those, kind of on the verge of perhaps coming onto the front as commercial products. So it's an exciting space. I think the AID issue, obviously my past life as the chief medical officer at Medtronic Diabetes was to bring out that first AID system. It does have some true advantages for patients, but not everybody wants one. So when we look at our users, many of them are using pumps in open loop. They just don't want to have an AID system, either because they're already doing so well on their own or whatever other variety of reasons. There's still many, many patients who don't want to pump at all.
Right.
They want to continue with multiple daily injections. I have patients of my own who are on multiple daily injections, some of them using inhaled insulin, Afrezza as well. And they are doing well. They all need a CGM. So many of them are using our CGM Eversense E3. in addition to multiple daily injections, maybe a Fressa, maybe a pump and open loop. Although, we think its advantages for patients, it's not there for every patient to need an AID or to want an AID.
What is it like? You mentioned, all these options. What's it like for you when you're still meeting with patients, you're still really right on the front lines of this, to be able to say to somebody who comes in and you have all these options, look at all these different things. I mean, it's hard to choose, but I'm personally so grateful we have all these choices.
Yeah, I think, the real challenge as a healthcare provider is meeting the patient where they are and what they want. I would say, not to super generalize, but some of my young adult women don't want a lot of stuff hanging off their body. And as a result, my first choice is to say, you got to get a CGM. I mean, that's number one. And then whether or not there's a pump that follows is, pretty much up to them. For some of them, the advantage of Eversense E3 is that I have to convince them to get a CGM, and they don't want to wear it all the time. They don't want something while they're either at their workplace or at their fun place. I'm in Southern California, so the beach is here. They don't want something hanging off them. So this is the advantage of Eversense E3. They can take that transmitter off. You see nothing on body. They'll do their finger sticks while they're at the beach, and then when they come home, they can put the transmitter back on without having to waste a sensor. I've got to work with each one of them. And of course, I'm part of a team at my center at Children's Hospital Los Angeles, where we do take care of a fair number of young adults, work with them to see what's going to work for you now. Of course, it doesn't mean that that's what we're going to have forever, although I do get caught up in having them, purchase one or another systems. They can get locked in for 4 years from their insurance company. So I want to be sure they understand all the options and all the advantages, disadvantages. And this is where, we're just hoping people will put Eversense E3 as one of those options in front of all patients considering CGM, because it is a unique offering. Again, that removable transmitter, those on-body vibratory alerts. If you travel a lot, you don't have to carry anything with you when you have Eversense E3, other than, just a few of those adhesives to change every day. You don't have to have half your suitcase filled with sensors. Depending on what job you have, we have somebody who uses it, who's one of our ambassadors, who works on the tarmac at an airport where he can't have his phone, he can't hear anything, and really relies on those on-body vibratory alerts. So we have some really significant advantages. Again, those who are worried about hypoglycemia, our great accuracy in that low range. And in addition, patients who are older, we have Medicare coverage, and patients who are older who lack dexterity or some, cognitive capability, not having to insert and remove the sensor themselves is, something that they truly appreciate.
I should have asked you earlier, for those who are not familiar, can you speak to the insertion and removal process? We've talked about it before on the show. We've had people who've had it done, but just in simple terms, this is, I would imagine, still pretty simple outpatient procedure.
Absolutely. So it's done in the physician office. And when I say physician, healthcare provider, because it can be done by a physician, a PA, a physician's assistant, or a nurse practitioner. It's a very short in-office procedure done under lidocaine, so you don't really feel anything. A very, very small incision. The sensor is inserted, and the wound, then the very small wound is closed with just steri strips. There's no sutures involved. And then you come back 180 days later, the small incision is made again with just a small little clamp. They pull out the sensor and then put steri strips on again and go to the other side to put the new sensor in, because we're labeled for the arms and we're labeled for alternating one arm and the other.
And I'm sorry for this. Steri strips are those like little tiny paperish Band-Aids. They're not stitches.
Yeah. But they're not stitches. They're little pieces of tape that hold wounds together. And sometimes even if you have stitches, they can put steri strips on over that, but we don't have stitches. And they fall off within about a week. And, that's the whole procedure. We're just hoping that people can see now 180 days, 6 months as a true advantage for them and consider Eversense as part of their diabetes armamentarium.
Right. Before I let you go, we've mentioned the travel that you've done, your work at Medtronic, your work here at Eversense, the fact that you're still seeing patients. Fran, why are you still doing all this? You could be on a beach someplace. You have done so much. You've been extremely successful.
If I was on a beach, somebody would have to tie me up there because that would not be my idea. I'm in my early 70s, proud to have been in the diabetes field again for almost 45 years. So excited about the progress we've made, but we're not there yet. So I want to be part of that journey as long as I can be. I want to interact with people like you, bring information and hopefully motivation to those who are living with diabetes so that they can live the best life possible.
Well, I'm glad you're still doing this. It's wonderful to talk to you. I always appreciate your time. Thank you so much for joining me.
Well, thank you.
You're listening to Diabetes Connections with Stacey Sims.
More information about Senseonics and about Dr. Kaufman at diabetes-connections.com. She really is just incredible. The more I learn about her, the more I realize she's really just had an incredible impact on the community, on technology, obviously, her time at Medtronic Diabetes, and on people one-on-one, not only continuing to work with patients, but, traveling. She's a medical director of camps. We didn't even get into that. And being part of Life for a Child. So I guess I'm in the Dr. Fran Kaufman fan club officially. But, lots more information on the product as well. And we'll be watching that closely, especially when it comes to interoperability, once they get that ICGM designation. Quick programming note and some fun stuff coming up. But first, Diabetes Connections is brought to you by Dexcom. And if you are a veteran, the Dexcom G6 continuous glucose monitoring system is now available at Veterans Affairs pharmacies in the United States. Qualified veterans with type 1 and with type 2 diabetes may be covered. Picking your Dexcom supplies up at the pharmacy may save you a lot of time, too. Connect with your doctor for more information. Dexcom even has a discussion guide you can bring with you. Get that guide and find out more about eligibility at dexcom.com/veterans. All right, we are coming up on Thanksgiving, which for many parents with some, newer diagnosed families can be a really stressful time when it comes to all of that food. I've got some episodes that we've done in the past, and I'll be linking them up in the next couple of days. But the episode next week is going to be with my daughter, Leah. And I'm so proud of her for talking to me and being honest. This is all about siblings and, how difficult it is. And I'm chuckling, and you'll know why when you listen to the interview. But how difficult it is to be a sibling of somebody with type 1 diabetes. Leah is 21 now, and she has such a great perspective, but she does not hold back. So I will be running that interview next week. But between now and then, I will be also linking up some of our past episodes specifically about Thanksgiving. We will not have a newscast the week of Thanksgiving. And in fact, I'm looking pretty closely at the podcast for what we will be doing next year. So I'll put this in the group as well. If you have strong feelings about what you're hearing, if you like certain things, if you don't like certain things, I want to hear from you. This show is for you. I hear very good things about the newscast, specifically from healthcare providers, but I'm not sure we need it every week. So we may be looking at doing it monthly or every 2 weeks. I'm not sure. As I'm sharing with you right now, you can hear it in my voice. So let me know definitely what you think as we are planning for next year. Also, I am finalizing, I cannot believe this, the early part of 2023. If you have an event, if you'd like me to come speak, I'm keynoting the Boston JDRF event in the spring. We've got lots of stuff happening here in Charlotte. There's a few other things that are happening, in the first and second quarter. If you'd like me to come speak, I have some new presentations. I'm very excited about this. Sure, I'm talking about my book, but these are also issues that impact adults with diabetes. It's not just about parents and kids, although that is a big part of it. So please let me know. If you'd like me to come speak, but you're not part of JDRF, call them up. It's as easy as that. Call them up and tell them, we'd really like Stacey to come speak at this conference. Or reach out to me, Stacey at diabetes-connections.com, and let me know where you are. And chances are really good I know the people there, so we can work it out. All right, that is it. Thank you so much for my editor, John Buchanan from Audio Editing Solutions. Thank you so much for listening. We do have a newscast this week, so I will see you back here in just a couple of days. Until then, be kind to yourself.
Diabetes Connections is a production of Stacey Sims Media. All rights reserved, all wrongs avenged.